Morning, everyone. We have a new sheriff in town today. Anyway, that's the way things roll. I call this meeting to order. Welcome to meeting 115 of the House of Commons Standing Committee on Health. Before we begin, I would like to remind all members and other participants in the room of the following important preventive measures to prevent disruptive and potentially harmful audio feedback incidents that can cause injuries. All in-person participants are reminded to keep their earpieces away from the microphone at all times. You do have a little sticker on your desk. As indicated in the communique from the Speaker to all members on Monday, April 29th, the following measures have been taken to help prevent audio feedback incidents. All earpieces have been replaced by a model which greatly reduces the possibility of audio feedback. The new earpieces are black in color, whereas the former earpieces were gray. Please only use a black approved earpiece. By default, all unused earpieces will be unplugged at the start of a meeting. When you're not using your earpiece, please place it face down on the middle of the sticker for this purpose that you will find on the table as indicated. Please consult the cards on the table for guidelines to prevent audio feedback incidents. The room layout has been adjusted to increase the distance between microphones and reduce the chance of feedback from an ambient earpiece. These measures are also in place so that we can conduct our business without interruption and to protect the health and safety of all participants, including the interpreters. Thank you all for your cooperation. In accordance with our routine motion, I am informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 1082 and the motion adopted on November 8, 2023, the committee is resuming its study of the opioid epidemic and toxic drug crisis in Canada. And I would like to welcome our panel of witnesses. And just for your information, this part of the meeting will run from 11 to 1, and then, of course, from 1 to 1:30, we shall have in-camera committee business. So, on the topic appearing as an individual, Sarah Lovegrove, registered nurse by video conference. Eugenia Oviedo Yucas, professor, School of Population and Public Health, University of British Columbia, by video conference. Martin Paget, executive director, by video conference. And Eleanor Sturko, member of the Legislative Assembly of British Columbia, Surrey South, here in person. Thank you all for being here. And with that, we will start our statements. You will all have 5 minutes. I'm a bit of a stickler for time. You will, when you have a minute left, I'm not going to cut you off mid-sentence, but you'll see me holding up the big 1 sign. We'll keep on track and have a nice meeting. So we look forward to hearing from you all. And with that, Ms. Lovegrove, please, you have the floor for 5 minutes.
Good morning. Thank you for having me here today. My name is Sarah Lovegrove. I'm a registered nurse and professor for the Bachelor of Science in Nursing program at Vancouver Island University. I'm grateful to be joining you today from the traditional unceded territory of the Sinemuk First Nation, colonially referred to as Nanaimo. I'm also an activist and member of the Harm Reduction Nurses Association, and I'm absolutely infuriated by the Federal Ministry of Health's decision to support and enable BC's political move to walk back decriminalization. So, drawing strength from the brave university students using their voice to stand up for justice, including the powerful students at VIU, as well as those at my alma mater of the University of Ottawa, I'll be taking this opportunity today to say what needs to be said. Because much like the genocide of Palestinians in Gaza, this worsening toxic drug crisis, killing 22 Canadians each day, is a result and perpetuation of the ongoing settler colonialism and white supremacy that makes up the fabric of our governments, policies, communities, and healthcare system. Indigenous people are disproportionately impacted by this crisis, experiencing death and injury related to an unregulated drug supply at a significantly higher rate than the rest of the population. Substances, like alcohol, were introduced to the Indigenous peoples of Turtle Island at the time of colonization and have since been weaponized as a tool of coercion and control to uphold the settler state.
Appel au règlement, Monsieur le Président.
Just 1 minute, Ms. Lovegrove, if you would. S'il vous plaît, Madame Roche.
Monsieur le Président, les interprètes...
Mr. Chair, the interpreters are deploring that the quality of the sound is insufficient to interpret.
Make it better for you. sound in the room that's too loud. My apologies, colleagues. We have had some problems with Ms. Lovegrove's sound originally. We thought it was good. It's not quite where it needs to be. So the suggestion that we'll have is, and I apologize to Ms. Lovegrove for that, is we'll halt your statement now. We'll come back and allow you to finish it. But I think we'll have to move on to Ms. Eugenia Oviedo Yucas, professor at University of British Columbia. So with that, Ms. Yucas, you have the floor for 5 minutes.
Thank you very much. I will try to speak slowly, as sometimes my accent might not be the best for the translator, so I apologize for that. Thank you very much for having me. My name is Eugenia Oviedo Yucas. I am a Latina woman. I am today speaking from the beautiful and ceded territory for the Squamish people of the water. I am a professor at the School of Population and Public Health. I am a Canada Research Chair in Person-Centered Care in Addictions. And following up the statement from Sarah Legrove, and as a continuation of what she was bringing up, one of the key things for continue this statement is the overdose crisis emphasizes that we need diverse strategies and action in cooperation is key. And the problems continue escalating. And we need thoughtful and intentional actions because this is not a problem with one face. And it's time to hold fast and continue moving forward, not retreating. We have a few medications in Canada that we can use for opioid use disorder that they are shown to be effective, but there are very few. There are a couple of other medication injectables that have shown to be effective, but they don't seem to be, roll out as we expected. As such, the way we deliver these very few medications don't seem to be enough to attract everybody, particularly if we leave the non-rural epicenters. So we need other strategies. We need to cooperate with other geographic areas. So we need, to be flexible. We need to designate facilities and expand take-home doses. We need more mobile, outreach, home-based models, other methods that have been established to be effective, to reach people with disabilities, to reach people that have caregiving responsibilities, to reach people that are far from the facilities. The people that we see come with many other issues not related to the medication, but, sustain, make people feel safe is the first step that we need. And for that, we need more than just a couple of medications that the system feels comfortable with. Using substances cannot be a criminal act, as it's not a criminal act to drink in public. Nobody goes to jail, but it's not allowed. All the problems that we have right now over decades and generations cannot be fixed in a few years. We need to be patient, compassionate, revise the evidence to make decisions. We need to continue improving, not giving up. Thank you for listening.
Thank you very much, Professor Yucas. Next on the docket, we have Martin Paget. Monsieur Paget, vous avez la parole pour 5.
Mr. Paget, you have the floor for 5 minutes. Thank you, Mr. Chair. Ladies and gentlemen, members of Parliament, thank you for inviting me to take part in your study. You've heard from a number of experts who are working at different levels to try to stem the crisis we're experiencing, and I'm pleased to be able to take part at a time of unprecedented social and health crisis. I am a father of 2 young children. I'm also a person with experience in the field and with academic knowledge who's been working in harm reduction for nearly 30 years. I've been a street worker in Montreal and Toronto and worked at the heart of numerous crises such as HIV, AIDS, hepatitis C, housing, COVID-19, and the current overdose crisis we've been experiencing for the past 10 years. I'm here today as executive director of the community organization called Dopamine. Our organization has been working with people who use drugs, and this for the past 30 years in the Hochelaga Maisonneuve district of Montreal. We're a well-established, well-rooted organization, and the organization works with a harm reduction approach supported by the best available evidence based on a number of studies. There have been many positive impacts on the health of people in the community in general that use these services. I'd like to tell you a little-known story about the people who founded the organization that I have the privilege of leading and representing before you today. The year was 1991. The HIV/AIDS epidemic was hitting Montreal very hard. In Hochelaga Maisonneuve, the health institutions were struggling to reach out to intravenous drug users. Montreal's public health department was setting up a pilot project to prevent infection amongst these drug users. The aim of the project was to equip community workers to distribute new syringes and condoms free of charge, but above all, to change fatalistic attitudes and the stigma associated with HIV/AIDS. Needless to say, the initiative met initially with strong resistance. But supported by health and political authorities, it was the street workers, the very peers of the people directly concerned on the ground, who helped stem the HIV/AIDS crisis. They saved untold lives. They helped make the neighborhood safer for everyone. With their courage, they changed the course of history. Since then, the entire Dopamine team has continued to develop solutions that are affected, adapted, and focused on real needs of drug users. They continue to fight to defend and improve quality of life, the right to health, but above all, the right to dignity. Faced with this new crisis, I stand before you in favor of recognizing the evidence, the science, and above all, the many experts working in every corner of the country to make a positive contribution to solutions that are definitely courageous and necessary. It's time to return to a pragmatic, humanist approach rather than fuel a divisive debate on our Canadian situation with moralistic, anecdotal, and sometimes even misleading approaches that only serve to maintain the status quo. We need to have courageous conversations and get down to work on the ground where human lives are being lost. We ask you to declare the overdose epidemic a public health emergency across the country, continue and guarantee a safer supply of pharmaceutical quality in keeping with the substance chosen by each individual, provide greater support to organizations to facilitate the development of supervised user services throughout the country, ensure that naloxone is widely available and easily accessible, purposely include the leaders in the drug-using community in all work that affects them directly, advocate for the decriminalization and even legalization of drugs. And I would add here that we need to rectify the ways in which the war on drugs has been used to disproportionately criminalize groups such as racialized and indigenous communities, persons living in poverty, queer and trans people who are currently hugely impacted by this war. I invite you to come and sit down with us. I invite you to come and talk to the bereaved. I invite you to come and see all the efforts we're making to reduce harm, reduce deaths, and save lives in our communities. We need pragmatic and humane policies to keep our communities alive. Thank you from the bottom of my heart for letting me speak. Thank you very much, Mr. Pagé.
I have Ms. Sturko. Ms. Sturko, you have the floor for 5 minutes.
Good morning, everyone. As the BC official opposition shadow minister for mental health and addictions and recovery, I'm here today to address the profound failure of British Columbia's illicit drug decriminalization pilot and its dangerously labeled Safe Supply program. These initiatives, while presumably rooted in good intentions, have unfortunately yielded alarming consequences due to what many forewarned as a lack of preparedness and vigorous oversight. In February 2023, at the outset of this pilot's implementation, I warned against the BC NDP government's lack of preparation and their failure to meet several criteria prerequisites outlined in the federal government's letter of requirements. These included expanding treatment capacity, engaging key stakeholders, and the development of monitoring and evaluation frameworks. And here we are 15 months later, witnessing the ramifications of not meeting those requirements. My worst fears that British Columbia was entering into an experimental policy without the necessary infrastructure safeguards, they have materialized, and the results have been nothing short of a disaster. Former Federal Minister Caroline Bennett promised British Columbians, quote, a robust set of indicators on both public health and safety that we will then monitor in real time, end quote. However, these commitments and transparency for real-time data have not been met. The absence of comprehensive data collection has directly compromised public safety, leaving our communities vulnerable. And it's British Columbians who are suffering with these consequences. Commuters are being exposed to toxic drug smoke on public transit. Children find discarded drug paraphernalia in playgrounds. And nurses, who should be safe in their workplaces, suffer assaults and exposure to toxic drug smoke within hospital walls. All of this occurring while the BC NDP government fails to provide equitable and timely access to health and social services to people suffering with addiction. Despite early warnings from law enforcement, critical safety and enforcement issues were overlooked, and the pilot program was allowed to commence without mechanisms in place to respond to problematic drug use and without the ability to deter behaviors that put others at risk. Moreover, the diversion of hydromorphone from the so-called Safer Supply program has persisted unabated since 2020. It took 3 years and substantial pressure from the medical community before a review was conducted in 2023. This review confirmed what many warned about: widespread diversion and limited evidence supporting the program's efficacy. Despite these findings back in BC, the BC NDP government continues to misleadingly promote this as safer supply. Tuesday's announcement from the federal government, which modifies BC's Section 56 exemption to prohibit public drug use, is a stark admission of the failure of government at both levels. Failure to properly consider public safety and confirmation of the danger and disorder that's been unleashed by this experiment. The modifications shift this crisis back onto the shoulders of police, who are being asked to move people along with no services to move them along to. It's merely a Band-Aid on a gaping wound, addressing public drug use, while doing nothing to address addiction itself. This policy U-turn does not address the core issues, but instead serves as political damage control, an attempt by government to mask the catastrophic outcomes and divert attention from the harms of their policies. This is an experiment that was doomed from the outset by a failure to provide social services, access to life-saving treatment, housing, and health care. Over the past 15 months, it's become painfully clear that the decriminalization policy has not saved lives. It has not reduced drug overdoses and instead has propagated harm and disorder throughout our communities. As we discuss these developments, we have to recognize that this isn't just a policy failure. It's a humanitarian crisis that continues to claim 6 lives a day in BC, and we cannot continue on this path. The decriminalization and safer supply experiments have proven ineffective and dangerous, and it is time for us to reject these policies. It's unacceptable to launch into population-level experiments, ignoring obvious harms and being selective in the collection of evidence. We need strategies that focus on comprehensive treatment options, social supports, robust public safety measures that genuinely protect our communities. We must develop policies rooted in evidence, prioritize public health, those that provide real solutions to the drug crisis affecting our province and our country. We must prioritize recovery, uphold safety, and secure a safer and healthier future for everyone. Thank you.
Ms. Sturko. Now we will go to rounds of questioning. The first. Oh, excuse me. We do. My apologies, Ms. Lovegrove. We are going to try this again. And Madame LaRouche, if you could let us know if there's any issue. Ms. Lovegrove, you have 2 minutes remaining, so we'll give it a shot, and I'll cross our fingers and toes. You have the floor.
I just want to make sure everyone can hear me okay. So considering that we are sitting at the crux of both Mental Health Awareness Month and National Nurses Week, I feel called to share my perspective on the complex ripple effects of this public health crisis within the
appel au règlement.
Point of order.
Order from Madame LaRouche.
Les interprètes.
The interpreters regret they don't have a sufficiently good sound quality to be able to interpret.
My apologies for that to all of you in the committee. We thought we had it fixed, but clearly we do not. A point of order, perhaps, from Mr. Julian.
Oui, juste pour.
Yes, Chair. Could the technicians perhaps try to intervene and improve the witness's connection and possibly have the witness speak a little slower might help?
We've attempted many of those things, but we'll continue to do that, and if we're able to resolve the issue, then we will. And if we've checked the internet connection, we have checked its speed, we've done the headset check, etc. It just doesn't, for reasons unknown, it doesn't appear to be working. So given that, we'll halt that at this point. Again, apologies to the witness and to the committee on behalf of all of us. So that being said, we will continue to work on that in the background, colleagues, and hopefully resolve that as the time goes on. And if it's the will of the committee, if we do resolve it, then I think it only fair that we allow Ms. Lovegrove to have her finish her statement if that works. It'll be a bit unusual, perhaps a bit clunky, but we'll do it anyway. So that being said, we'll start a round of questioning now. Ms. Goodridge, you have the floor for 6 minutes.
Thank you, Mr. Chair, and I want to thank all the witnesses for being here today and providing their testimony. Professor Oviedo Yux, I understand that you were involved with both the Naomi and Salome studies, which are used as the evidence that brought forward the safe supply programs. And my understanding is that both of those studies used witness dosing. Is that correct?
Yes, that's correct.
So based on that, a study that used witness dosing, how can it be used as evidence to support giving take-home pills of 30 to 40 dilaudid hydromorphone pills a day?
Well, first of all, the study, as you said, was injectable, and we do hope that people that are ready for it can take the doses with them in the cases that are indicated by, the prescriber in a conversation with the physician. There was always the intention that as clients evolve, the treatment will evolve with them. We did have...
Did the study look at that evolution?
No. We didn't. We had a trial, and the trial ended, and we did show that for our participants, injectable was more effective than oral.
No, I appreciate that. So does the diversion and the reports of diversion that are happening of the take-home hydromorphone and dilaudid pills, does that concern you?
First, the diversion that is shown is so minimal that for the scientific perspective is expected for the number of people. in a big scope, there is a very small percentage of people that are struggling with opioid use disorder that are getting the diluted pills. So the possibly expect the number of people that might be sharing or selling the medications, because that's not the medication for them, because we have few options, as I said at the beginning.
So just to
it's a number
clarify,
that is expected.
just to clarify, so the amount of diversion that's happening provides no concern to you whatsoever?
It's expected.
Okay, I appreciate that. Alors, je vais demander.
I would like to address my next question to Mr. Paget. Of the 49 districts in Montreal that were assessed by the Montreal Police Force in 2021, Hochelaga Maisonneuve, the district where dopamine's located, is ranked 4th for crime levels with 57.7 crimes per 1,000 inhabitants. Given the numerous playgrounds, schools, and the Edmond Hamelin Park that's just on the other side of the street, what measures have you put in place to make sure that drug injection sites where you have crack, heroin, would not worsen the already very disastrous criminal situation in the district? These supervised injection sites at dopamine are contributing positively to eliminate consumption in public areas. So these injection sites make sense and contribute positively in a community where well before the presence of our organization, there was a very precarious social crisis, not just in connection with drugs, but just in connection with the long-standing poverty in this area. So the presence of dopamine had been helpful. People come and use our services that are supervised rather than consume in public spaces that are unsupervised. There has not been an increase. There has even been a drop. We've, in terms of, syringes found in public spaces, there's no increase. There's a drop, in fact, in consumption. I have very little time. Thank you. I have seen in the news that parents have concerns about their children being very close to the dopamine center. What are you telling parents whose children play nearby? I don't know if you have much information about our organization. We don't have a school next door. Dopamine has always played a very positive role in terms of communicating with the community, because we're rooted in the community. We emanate from the community, including the schools. There's never been a single incident, not one.
Sturko, one of the things that you said that really kind of hit me was you said that it was effectively a Band-Aid to a gaping wound. What have you seen as in your role in British Columbia, both as an elected official as well as a former law enforcement, when it comes to diversion? Does diversion scare you?
Yeah, I have a lot of
Ms. Sturko, if I
concern.
might interrupt, you have about 5 seconds to answer that question. You may have to come back to it.
Sure. Then I will just say in 5 seconds that yes, diversion is a concern. It's something that I've heard a lot about, and I look forward to speaking more about it when I have longer than 5 seconds.
Thank you very much for that. Suite, Madame Lapointe.
Next, Ms. Lapointe, for 6 minutes. Thank you, Chair.
Oviedo jokes. So in my community of Sudbury, I will tell you that we had the highest number of opioid related deaths per capita in the entire province of Ontario. So it is a very critical issue in my community and across Northern Ontario as well, and where we really have a lack of resources and a lack of infrastructure. And so I would be very interested in hearing your thoughts on how we can better support people who use drugs that live in rural and remote communities.
Thank you so much, and I'm very sorry for the circumstances in your area. So the first thing, as I was saying, is collaboration is key. There is nothing that will come from the top that can work unless we work with the community. We understand what are the values of the community, because just coming and saying, take this, do this, without knowing if this community is ready and is going to accept and work from there, trying to offer all the options that we can do. As I said, each group of people, particularly priority settings, have defined issues that we need to work with. Some of them is the medications are not available. People cannot travel. That will be a very key problem that has to be resolved. And then the restrictions in policy will be a area that we are hoping, can we just solve that from the provincial or the federal government so we can reach all the people in the community, people with disabilities that won't be able to come daily. Are we those other intersections that we might have? Sometimes women will not want to be in a place where, people that have been violent to them are in the same place. So that's kind of the idea where to go, to start working together and understand what are the issues in the community and see how can we build together that side. I'm not sure if I answer your question with that.
Thank you, Doctor. So in your opening statement, you said we need to be flexible in dealing with the opioid epidemic and toxic drug crisis in Canada. So tell us, what does flexible look like for all of the agencies and levels of government that are involved?
Well, when we discuss and do work with the prescribers and they want to do person-centered care, they do know that certain clients require an opioid medication that they cannot prescribe because it's not it's not indicated for opioid use. So not all, you see, in downtown Vancouver, you are going to be in the advocacy group and you are going to be able to prescribe off-label. But in other places, you don't have that support. You're alone. So you can prescribe only a few things. You don't have prescribers. So the idea is to have the flexibility that we can have all these medications that we know are evidence-based available. So when you have a client coming to you, you can have a conversation with them and say, don't leave. I have something for you. This is the medication that is going to be the best fit for you. Maybe that person is not ready to take home. But, work with them. Maybe that person is ready for somebody going with them or a family member helping. There are so many ways to work with people that are not either supervised or just let them on their own. Did that answer your question?
Yeah, thank you, Doc.
Okay.
I noted that you are a Tier 1 Canada Research Chair in Person-Centered Care in Addiction and Public Health. So can you share with this committee your thoughts on how Canada can ensure and even improve our decision-making based on evidence-based practices, both here and what are some other models perhaps outside of Canada that we could be looking at in terms of good evidence-based practices?
Thank you. Well, the first thing is there is evidence that the so-called experiment did save life, and the BC CDC had published in the British Medical Journal that it saved lives. So the first thing is, if we are going to dissent, let's dissent with the truth. It is totally fair to dissent. But let's dissent to the truth so we can build, not going backwards. Let's build. Because we are always short on services, always short. So we have decriminalization works, and has worked in every country. people going to jail because they use substances doesn't work, maybe in China, but doesn't work. So let's build and do it better, not worse. So one of the things that we see is the little things that we achieve are kind of like, we need to do it better. What can we do better? What can we add to this? That's kind of the idea. Either if you disagree with what measure, build something on top of that. Let's just not destroy the little things that we are building together. At the end of the day, we are in this together. When people die, they don't have a party patch here. They just die. Most of the people that die are poor people.
Professor, I'll have to stop you there. Your time is up, but thank you for that. I appreciate it.
Thank you. Sorry, I didn't know I have time. Sorry.
Colleagues, what we are going to try one more time, this will have exhausted all possibilities. It's a bit unusual, as I said, but with Ms. Lovegrove, we have tried disconnecting and reconnecting. So assuming it's the will of the committee that we'd like to hear from Ms. Lovegrove, if possible, I see general agreement with that she does have 2 minutes left. So we will try that again. Ms. Lovegrove, you have the floor for 2 minutes.
Thank you very much. So as I was saying, I feel called to share my experience on the complex ripple effects of this public health crisis within the context of concurrent national healthcare crisis and provider shortage. Canadian nurses are leaving the front lines in droves as a result of burnout, moral distress, moral injury, and trauma. And I'm speaking to this specifically today because I was one of them. I left my job in the Nanaimo Emergency Department.
Excuse me, Ms. Lovegrove. Could you just speak a little slower, please? Perhaps that may help too. Thank you.
Okay. I left my profession altogether with severe post-traumatic stress disorder in 2018, having worked through the first peak of the fentanyl poisoning deaths and at the time of Nanaimo's largest homeless encampment, Discontent City. The devastating psychological impacts of participating in countless failed resuscitation attempts, witnessing discriminatory and stigmatizing treatment of people who use drugs, having sick patients leave before receiving treatment due to fear of criminalization, and not having the necessary resources to care for people in the way I was trained to do nearly killed me and left me hopeless, thinking that I would never have the capacity to return to this profession that I love so dearly. Due to the increasingly toxic and unpredictable nature of the unregulated supply, people who use drugs are becoming injured and dying at escalating rates in ways that we have never seen before, and frankly, in ways that the Canadian healthcare workers are not prepared to deal with. This is happening because of decades of bad drug policy that reduce people who use drugs to be less than human. Now, as a teacher, I'm obligated to armor my compassionate young nursing students in preparation for a career that will most likely injure them as well. I will reiterate that this is a public health crisis, not a political opportunity to garner votes during an election cycle. The politicization of this crisis is killing people, and the reactionary implementation of policy is only feeding stigma and contributing to the fear-mongering spread of dangerous misinformation. In the past few months, BC has seen a marked decrease in toxic drug deaths, but after this week's decision to recriminalize substance use, it breaks my heart and spirit to know that even more people will die. The evidence is
I'll have to stop you there. You'll have lots of time to expand during the question and answer period. But thank you for your patience, and thank all of you for your understanding. Suite, Madame Larouche.
And now, Ms. Larouche, 6 minutes. Thank you very much, Chair, and thank you to all of our witnesses today. You've made us realize the broad scope of this crisis and the importance of working seriously on an evidence-based approach. Mr. Paget, first questions are for you. Very quickly, as a teenager, I met with the people from Cactus, and their testimony most certainly influenced me in wanting to turn to the profession of social work. And I wanted to hear you talk a little bit more about your organization. You did clarify that there's no schools close by where your organization is located, but what is close by? There was a question earlier about policing services. Now, this approach does involve a continuum of services. So what is in the surrounding neighborhood, and what's your ties with the policing services? Thank you very much for your question, Ms. LaRouche. It's complex. I probably won't have time to answer everything. We have two service areas. So in our first facility, we are near a park. The park is just across the street. There's also housing, modest housing in the neighborhood. So Dopamine has been there in that facility from 2013. And so it's been located, rooted in the community for a long time. We are careful to not leave syringes lying by. There's good harmony. Now, we also have another facility on Ontario Street. That's where we have offices open day and night. Now, there is a school, a high school nearby, but Dopamine services there are at night, so there's no friction. Although the schooling authorities, be it on St. Catherine Street or on Ontario Street, have always had good ties, very frank ties with us and the citizens in the community. I'm trying to be quick. As to the ties with the policing services, Dopamine has always had administrative communications with the neighborhood police station, and the police officers understand our mission. They understand what we're trying to do in the community, and they're there to prevent any incidents. So good communications is everywhere and at many levels, and Dopamine, as I said in my opening statement, is well rooted in the community and has been welcomed in the community for more than 30 years. And this, of course, well before the services we provide for safe injection sites. So we have good ties. Thank you very much, Mr. Paget. I'm glad that you mentioned a bit about Hochelaga Maisonneuve. We know that the history of that district dates way back. You also wanted to enlarge some of your facilities and services in the forthcoming year. Were you able to do so? Can you talk about this a little? Point of order. Point of order. Online, the interpretation services are not coming through.
Une pause sur mon temps.
You're never going to want me to sit in the chair again. I'm not suggesting, Marcus, that you want me to sit in the chair today. Colleagues, we're going to have to suspend for a few minutes here.
Thank you so much, Chair. Now, Mr. Pagéal, just to repeat my question. I know that you have a project underway. You wanted to enlarge and have an inhalation facility. Can you talk to us a little bit about that project? Thank you very much. Well, yes, the idea, given the current situation in our community, we have to try to provide services both day and night to meet people's needs. So the two facilities are complementary in terms of their scheduling. So for the day schedule, we have not had any injection or inhalation therapy facilities. So we have the green light from the public health authorities. We're at the very, very beginning of that process. And we have to test the feasibility of that. And that is why we have asked for help to institute those projects, because it's going to improve the quality of life in these communities and in the supervised injection sites. And it's complementary services day and night. That's the reason for the project. But we're at the very beginning of that. So what added value will it provide for those people that you're providing services to? Save lives, save lives, save lives.
Merci.
That was
Thank you.
done in under 10 seconds. Terrific. Next, the final 6-minute round to Mr. Julian. You have the floor for 6 minutes.
Thank you very much, Mr. Chair, and thank you to each of our witnesses. The reality is your testimony is indicative of how important it is for us to ensure that we are bringing down the death rates across the country, every single death. And as you mentioned, Ms. Lovegrove, in your presentation, every victim represents the end of a beating heart, and it represents a family and a community that is mourning. And so we have to take action. And I wanted to start off by asking Ms. Oviedo Joques and Ms. Lovegrove the following questions. What should the federal government be doing more? Should it be declaring a national health emergency as we see numbers climb in Alberta and Saskatchewan? Should it be putting into place funding for safe consumption sites so that we can bring the death toll down, particularly on the prairies, which is staggeringly high and increasing daily? And both of you mentioned, Ms. Oviedo Joques, you talked about dissent with the truth. How much harm are people doing, politicians doing, when they say things that are simply not true when it comes to dealing with this public health care emergency?
I will allow Sarah to speak since first.
Thank you. I thank you for the question. It's my full wholehearted belief that we need to be doing absolutely all of those things to curb this crisis. The federal government also has the opportunity to regulate the drug supply and offer a legal supply of drugs to the entire country to curb the deaths that are a result of the unregulated toxic supply. So we need to be declaring a national emergency. We need to be instituting overdose prevention sites in every single community across the country, investing in harm reduction, and absolutely offering a regulated, safe supply to everyone in this country.
Ms. Lovegrove, on my second question, the issue of being truth tellers, how much harm are those who are falsifying, providing false testimony or false information, how much harm are they doing?
They're doing irreparable harm to this country, to the people who use drugs in this country. People are dying as a result of stigma and people aren't accessing services as a result of stigma. And when politicians utilize this as an opportunity to get election votes or get ahead in their careers, they are doing harm that is killing people. And they need to be rooting with their decisions and what they say in public with evidence and utilizing the expertise of people like the witnesses here today, rather than listening to the opinions and prohibition-era stigma that is feeding the opinions of folks across this country and only further inflaming the stigmatizing belief system around substances.
Thank you, Ms. Ovedes. The same question for you, both in terms of what we need to do, but also in that dissent with the truth that you spoke about.
Like following out what you're saying, we need to have all the options open for people. We don't know where, if I was a person struggling with drugs, where I'm going to be today, in 10 years. It is not, it's not a death sentence, but it is demonstrated that treatments that are based on not using any substance, so-called abstinence-based, have a success rate of 5%. 5%. So just holding the bandera, Spanglish, of that's what we have to do is not good for people, because there is not one treatment that we need to proclaim. We need to proclaim all of them, because people are going to be in different places at different times. So we need to proclaim a young person might be wanting to be in that path. Another person might be ready to start out with orals. Other person, the only thing they want might is injectables. Other person, the only thing, evidence-based. If we go and lie and say, it is proven that this didn't work, and you have authority, and you have the floor, and you just said that because you saw it in the news, what you create is panic, fear for the people that have children, for the people that don't read. And then you get an entire community saying, this doesn't work. Abuse of power is not a good thing.
Can I?
So go for it.
Yes, I'm deeply saddened by the Alberta death rate, now the highest in the country. The death rate in Lethbridge, 137.5 per 100,000. Deeply saddened by these statistics, a 17% rise in Alberta, a 23% rise in Saskatchewan. When we talk about these tragedies happening now in places like Alberta and Saskatchewan, what is your reaction?
I'm very sorry, but we are already over time. So, Mr. Julian, you'll have to hold that question and answer for your next round. Thank you, colleagues. Next round, we'll be moving into different amounts of time. So I encourage the witnesses to listen carefully as to how much time the questioner has to answer the question. With that, Dr. Kitchen, you have the floor for 5 minutes.
Thank you, Mr. Chair, and I appreciate, and thank you to all the witnesses that are here today. It's greatly appreciated. I'll start with Mr. Paget, and I apologize, je parle un petit peu, mais...
I do speak a little bit of French, but I speak the language very slowly.
And I actually found it quite interesting that your organization is called Dopamine. And I find that interesting because, I mean, 80% of the catecholamine content of the brain is basically what dopamine is. And it deals with pleasures, satisfactions, motivation. It also deals with concentration and movement. And so I found it interesting to how you use that as the name for your organization. But you also mentioned about naloxone and talked about it. And the impression I got from that conversation was that it wasn't readily available or to a great extent in your area. And over the years and in my discussions with paramedics, et cetera, that's been a big concern for paramedics actually being able to utilize naloxone. And the concerns that in some cases where they are utilizing the naloxone and then have to step back because of the fear the moment they give that naloxone to that patient, when it brings that person out of the state that they're in, they often come out in a violent manner. So I'm just wondering if you would mind commenting on the aspects of naloxone.
Yes. And I hope I've understood your question properly. When I mentioned naloxone and the importance that it be accessible and that it could easily positively contribute in communities, it's because in some place naloxone is more difficult to access, unfortunately. But naloxone is an effective antidote to deal with overdose. As to fears of first responders, oftentimes it's not a violent reaction that the user suffers. It's, it's the bodily reaction to the withdrawal. So sometimes those who do get the naloxone are, relieved that they're still alive. So you have to keep the right balance in the discussion. Naloxone saves lives. It's the antidote effect that the person getting the naloxone feels the symptoms of withdrawal. But I've never heard any anecdote where they have come out of their overdose in any violent way. Of course, you need to have the right techniques, not just to administer the naloxone, but also work with people who are drug users. Thank you.
Mr. Sturko, and thank you very much for coming, and I appreciate you being here in person. And you touched a little bit on treatment and rehabilitation, and I think when we deal with Canadians and Canadians that are watching this debate that we're having here, and a lot of them are concerned about that. I mean, where are the steps that are being taken to rehabilitate and to and that prioritization of that recovery, I think, is a very important thing. And when we look at the fact that 23,800, more than 23,800, basically people due to drug addiction are having hypoxic brain injuries, and the huge impact that that's going to have on provinces, on how do you deal with those individuals and caring for them. I'm wondering if you would mind commenting on that.
Yeah, thank you for the question. So, what we're seeing in British Columbia is certainly a large number of people that have acquired brain injury as a result of overdose. I myself have administered naloxone to people in the course of my duty. I'm a former RCMP officer. And I can say, one of the things that, really worried me is that, at times there was I'd get dispatched to a call for a person who was unconscious and suspected overdose, no ambulance ready in BC. And what ended up happening is it would take me 5 or 6 minutes to get there. And that person all that time either has very shallow and not very much breathing or not breathing at all. And then of course,
Ms. Sturko,
naloxone.
I'm sorry, I have to interrupt you again. The member's time's up. I apologize for that, but you can get back to it, I'm sure. Suite, Madame Brière, vous avez...
Yes. Ms. Brière, 5 minutes.
Mrs. Sturko, in your remarks, you were saying that indicators haven't been met. I'm PS to the Minister of Mental Health and Addictions. Health Canada is monitoring the BC's indicators and is telling us they are met. Could you please tell us what are your sources?
So what I'm referring to, ma'am, is what was promised by the minister. and then what was delivered. And I can share with you a little bit about what was actually promised by the minister at the time. It was we would be getting baseline indicators, that we would have a robust set of indicators on health and public safety. The minister, who was Carolyn Bennett at the time, in May of 2022, said that we would be able to ascertain not only how many lives are saved, how many emergency department visits, how many hospitalizations, and from what we were hearing at the time from urban mayors about petty crime. And she said all the things that we know are indicators of whether we're really stemming the tide of this crisis. Okay, so I just want to go then 8 months later. There was another press conference in British Columbia, and that was at the outset of the project, the pilot. And at that time, Minister Bennett said, I would say that we need at least, and these are quotes, by the way, sorry, I would say that we need at least 3 months to be able to get this sorted out. Also, I think as we let people know what the indicators that have been chosen, so 8 months later, they didn't have the indicators chosen, it seems. If people have ideas or they have other indicators that they would like, whether it's a small business or whether people are saying, what would be other things that we could be measuring that would help determine the efficacy? So one of the things that was in the letter of requirements, ma'am, was that the amount of treatment and health care would be scaled up. There was a study that was released for the community, or the Journal of Community Safety and Wellness, and it had stated in that just prior to decriminalization coming into effect, that 64% of the communities served by the RCMP in BC did not have any access to any drug rehabilitation or treatment. So that means the majority of British Columbian cities did not have any access to these services. And while that is not the only service that should be provided, it was one of the requirements to scale up these to make sure that we were ready for, as stigma would be driven down and that people could be connected to services, that they would exist. And unfortunately, they just haven't existed.
Okay, but all these indicators are posted, and Health Canada confirmed they are meeting the letter of requirements.
Well, ma'am, the other part of it, too, is that in the beginning, Minister Bennett had promised citizens of British Columbia that we would have a dashboard that was going to be updated monthly, that dashboard would be publicly facing, it'd be monitored in real time. Then the context of sort of the data collection was then altered, and that was then allowed to become a selective snapshot. And I can tell you very concerningly, actually, one of the pages of the snapshot up to 2024 April, that's the most recent one. What is provided there is the number of sort of treatment beds and individual clients that are served. Unfortunately, the snapshot is from the fiscal year 2022-23. So it only actually encaptures 59 days of decriminalization. And so, for us to be able to actually say at this point that they've captured data that would suggest that they could understand fully that people have accessed more treatment, there's no indicators on whether or not that was successful, whether or not people actually stayed in those services, and it's very concerning.
I have some quotes coming from you in October 2023. You were saying that this government has introduced a safe supply where they're giving hydromorphone. They give it to individuals to help get them off illicit drugs, and that we need to continue exploring. You also said this government was said to be exploring options for pharmaceutical alternatives to illicit drugs, and that's what they should be doing. We absolutely support harm reduction. I would like to know if you still stand by these quotes.
I think that what's important to note is that the concerns that I've raised over the last, I'd say, duration of my time as a member of the Legislative Assembly is a lack of evidence of the efficacy of the program, but certainly the absolute failure to look at things that are potential harms on the community. So while it's important that we continue the research and finding ways to treat people and to ensure that they can be protected from overdose through things like pharmaceutical alternatives under supervision and witnessed programs. Very little data, if any at all, in British Columbia has been actually collected on things like the diversion of safe supply, which is of extreme concern to me.
Ms. Turco, I have to interrupt you again. I apologize. I'm like the interrupting cow joke that you've probably heard from your kids. Anyway, that being said, I do apologize for that. But Madame LaRouche, vous avez la parole pour 2 minutes et demie.
Thank you, Chair. I would like to turn to Mr. Paget. I would like to come back to your testimony, and I would like to understand. There's a lot of talk about cohabitation in the community where there are organizations like yours. So to have people who are suffering with addiction, and we have people in the community, should they have more supervised injection sites? We talked about your expansion project. Now, you have these sites where there's drugs that are inhaled. Can you talk about what you do to enhance this cohabitation? Thanks for the question, Ms. LaRouche. The importance of having more services is important. These projects have been working well for many, many years. So we're talking about safe sites, but we can also talk about prevention of infectious diseases. So it's people who consume drugs in a community be in contact with community workers or health care workers so that prevention work can be done to help them with their health in the long term. And then, of course, there's cohabitation, because we don't want these addicts to be hiding in, narrow, hidden laneways. We want them to have access to all the care day, evening, and night. I had talked earlier about communication. You do need good communication. Community organizations need to be sufficiently financed to be able to maintain services in place, but also to have workers who are in contact with people in the community. I'm talking about street workers, and then you have, the healthcare workers working in the schools. So you need to have good communication between all of the different workers. Now, the purpose is to save lives, to maintain good quality of life during people's addiction periods. But you can't start confusing the concepts. We're not asking people, to just love each other, but we want good communication, and we need to save lives. Thank you very much, Mr. Paget. There's little time.
Mr. Julian, you now have the floor for 2.5 minutes.
Thank you, Mr. Chair. Ms. Turco, welcome. As British Columbians, we have a responsibility. I think we would agree. We have to get a handle on this toxic drug crisis. And I appreciate you being here today. I'd like you to tell us what the death rate for toxic drugs in British Columbia was in March 2023 and what it was 1 year later in March 2024, according to the BC Coroner Service. Okay, I'll tell you, it was 46.2 in 2023. It was 40.3 in 2024. And that difference means the savings of hundreds and hundreds of lives in British Columbia. Now, as Ms. Briere asked you, you have been on record, and I know in conversations with you before, you've said that things like, we are not backtracking on the need for harm reduction. With our whole hearts, we want to save people. We support decriminalization and harm reduction. You weren't clear in your answer to Ms. Briere. Have you changed your position on decriminalization? And given these figures, why would you not be supportive, though we need to tweak and improve the program, why would you not be supportive when lives are being saved?
So first of all, yes, I have changed my opinion of decriminalization. And I want to be clear, too, that, it is important to note that there have been, even in previous years or months where we saw decreases in overdose deaths, even several months in a row, only to be followed then by increases. And, this is certainly the case. I actually this was something, I've heard people on this committee speaking about before, and so I can tell you that in multiple years we have seen trends like this before, only then to spike up in other months, and then to be followed by, again, year after year, the worst records for overdose deaths that we see.
I'm sorry, it is my time. It's very short. I wanted to ask you about Moms Stop the Harm. Have you met with them?
No, I have not.
Okay. These are families, victims of the toxic drug crisis. They have been very strong on having a range of services, including harm reduction, decriminalization, safe supply. Why would you not meet with them to hear those families out and understand the importance of having a variety of tools to lower the death rate, which I think is something
I'm sorry, Mr. Julian. You're well past time. I apologize for that, but I ask all members to watch their time closely. And Ms. Sturco, hopefully you'll have time to answer that at some other point. Of course, you could submit in writing to the committee. With that, we'll move on to Ms. Goodridge. You have the floor for 5 minutes.
Thank you, Mr. Chair, and Ms. Sturkle, you're going to stay on the hot seat for a little bit longer. When you haven't had an opportunity to explain your concerns around diversion due to some of the time constraints. As someone that lives in the Lower Mainland, represents a Lower Mainland riding, and former law enforcement officer, how concerning is diversion to you, and what have you seen on the ground in British Columbia?
Yeah, so I guess my concern with the diversion of safe supply is twofold. The first one, and probably the one that's hit me the hardest, really, is the impact that it's had on young people. I've met with physicians, but I've also met with the parents of young kids who succumb to overdose. One of the first dads that I met with, his name is Dave. His daughter died of a fentanyl overdose. And at the time of her death, she had several bottles of safe supply hydromorphone in her bedroom that were not prescribed to her. And in talking to him, he said his daughter had started with cannabis and then moved on to experimentation with other drugs. And that was alarming to me. I think that given the fact that there hasn't been any study really in British Columbia about what impacts the diversion of hydromorphone is having on the overdose crisis, I think it's something that needs more attention. The second concern that I have is that we are seeing now in British Columbia that diverted hydromorphone is being discovered by police in their drug investigations, and police have even testified, I think, to this committee that there is a nexus between some of these investigations and organized crime.
So you're effectively saying that police in British Columbia are figuring out that government safe supply, or so-called safe supply, is fueling organized crime and gangs?
Yes. So police have, put out news releases, have reported in the media about drug investigations that have nexus to organized crime. Gang activity in British Columbia is obviously a concern, and so any kind of diversion or government program that would in any way put money into the hands of organized criminals and gangs is a top concern. That doesn't mean that we have to stop helping people, but when there are ways that we can mitigate risks and in fact help stem the flow of drugs into the hands of criminals, we absolutely have to do that.
One other piece that I find really interesting is in British Columbia, the overdose rates for kids in British Columbia is steadily increasing. And the children's minister actually stated that she thought that the Minister of Mental Health and Addiction here federally was doing a great job and had faith in this policy and the direction. And so I'm just curious, when you hear of things, we know that opiates are highly addictive. We've had many doctors come present to our committee on this. What is the impact on the families that children started out on this so-called safe supply that they believe is safe because it's been marketed as safe?
Yeah, so one of the most, I think, impactful and devastating stories that I heard firsthand from a father named Greg. His young daughter started using drugs at age 14. She died at age 15. And what the widespread impact was is that actually her group of friends was using drugs together. One of the kids in the friend group is still living. And she said that they did start off by getting dillies, which is the street name for Dilaudid, for hydromorphone, and they did think it was safe. They started to become sick when first they started off by taking it once in a while, started feeling, the need to take it more, and then it came to the point where if they would stop taking it, they would feel sick. And then when the withdrawals were no longer being managed even just by taking the dillies, the one girl who actually survived started taking fentanyl. And even though she had access then to OAT, she still continues to use drugs now. I know her mother very well, and it is an absolutely awful journey that they're on. There's not enough supports and services, but this is widespread. And especially when we're talking about kids or even young adults or adults, it's affecting their friend groups. And I think one of the biggest things that's really concerning to me, and if I can just read this into the record, this is actually just right from the Dilaudid. So this is from Purdue Pharma. This is their patient medication information. And it says, never give your Dilaudid to anyone. They could die from taking it. If a person has not been prescribed Dilaudid, even taking one dose can cause a fatal overdose. This is especially true for children. It also says, even if you take Dilaudid as prescribed, you're at risk of an opioid addiction, abuse and misuse. This can lead to overdose and death. To understand your risk of opioid addiction, abuse and misuse, speak to your prescriber. So, my concern is the lack of
Ms. Turco,
research
I'm sorry,
on this.
I'll have to interrupt you there. I think that's a good place to to stop. Next up, Dr. Pelosi, you have the floor for 5 minutes, please.
So we've heard both sides on the issue of safe supply. We've certainly heard people say that there's plenty of evidence for the beneficial effects of safe supply, and by that they meant the Canadian version of safe supply, which is getting a whole bunch of Dilaudid and going home with them. We've also heard the opposite from members of Health Canada, who generally seem to be supportive of the idea. However, they admitted there wasn't a lot of evidence for a safe supply in the Canadian context. We also heard the same thing from the Stanford Lancet study, where they were very much against safe supply. And I would note that the BC health officer in his review, or her review of safer supply, also said there wasn't a lot of good evidence for safe supply. Now, what there is a lot of good evidence for is IOT, intravenous opioid agonist treatment. Naomi and Salome, as Ms. Goodrich pointed out, were directly observed treatment. A lot of the evidence from Switzerland and the studies, which are again cited as evidence for safe supply, those too were observed treatment with injectable drugs, heroin at the time. So given this, and given the concerns about diversion, which I think are totally legitimate, and that's why the Swiss have this approach, because of the concerns of diversion. Given both this and given the fact that a lot of people in BC continue to die because of fentanyl, that's what's killing them. And even though they get Dilaudid, it's not enough for them. They use fentanyl. What do you think about intravenous observed treatment in this kind of Swiss model, that people can come into a treatment facility and get observed injectable doses of fentanyl? Would you be in favor of that, or at least willing to contemplate this?
Actually, something that I wrote a letter to Minister Yara Sachs, and I also carbon copied that to Premier David Eby, that I actually was supporting a call from doctors across Canada, addiction specialists, including 72 in British Columbia, who were calling for witnessed prescribed alternatives that are recovery-oriented. And of course, my purpose in coming here today isn't to stop people from getting life-saving medications, if this is what is important. What I want to make sure is that we understand the scope of the risk to the population. And there is a population-level risk, even identified by Dr. Henry, for example, in her report that you referred to, that was released on February 1st. So, if we go and we're going to be providing treatments, which, as you stated in Dr. Henry's report, has not enough evidence at this point to be described as fully evidence-based. We need to make sure that we're not causing unintentional harms.
No, I've heard from addiction specialists who are in favor of IOT that our safe supply was kind of a poor man's version, because IOT, when you bring people in and you witness them getting injections, is a lot more costly. That is obviously an issue for governments. Do you think we should be putting more money into providing more of that kind of therapy versus the present kind of safe supply?
It's a pay now or pay later scenario.
It's a what?
It's like pay now or pay later. And what is the cost of a life? When we reduce these things to what will it cost, and we look at the human cost. 6 people a day in British Columbia losing their lives. And I think that if there are alternatives that can protect the public from diversion, make sure that we're ramping up things like prevention strategies and actually warning people that it is not safe to take other people's medication, and actually safeguarding the public. Of course, we need to invest in a whole scope of services, but also in social supports, housing, things to help people become stable, so that if they do access medical programs, that they have the social stability to maintain their use of those programs.
Maybe I can ask this same question to Professor Ovidio Jucas. Should there be more facilities that would allow directly observed treatment, including potentially intravenous and or smoking drugs as an alternative to the present safe supply with pills that you go home with?
Definitely an alternative, and not just maybe open new facilities, but integrated on the services that you already have there. Open new facilities can be costly. If you integrate it on the services, you make it mainstream, and then people that leave a treatment can go to another if they are ready to switch from injectable to oral medications. That answers your question?
Yeah, thank you.
Thank you.
Thank you very much, Dr. Pawlowski. It's a good time to stop. So, colleagues, just so everyone has an idea of where we are, it appears that we have at least one more round, which will take us about 25 more minutes or so. I think that that's probably a good place to stop then, just so everybody has some idea of where we are. So with that, Ms. Goodridge, you have the floor for 5 minutes.
So after 9 years of this NDP Liberal government, we have tragically seen over 42,000 overdose deaths, rising child overdose deaths and rates. Do you think that the Trudeau government is doing a good job at managing this crisis, Ms. Sturckow?
No, I don't think the governments at either level are doing, both provincially and federally. I think that not enough emphasis has been put on prevention, certainly. And, we keep having these discussions about individual services, which, while important, what we really need to do is start developing a true framework for both the country and for individual provinces that is a recovery-oriented system of care that has strength in all 4 pillars. Not the one-legged stool of simply trying to, look at one service option at a time, but vastly scaling up all parts of the pillar, including enforcement. One of my greatest concerns, honestly, is the lack of prevention that we have and education. And I'm especially troubled to see young kids and families, and especially having to meet with families of people who've lost a child. And I really want to be strong in my statement here, I guess, today is, this isn't about stopping people from getting help, but this is about making sure that when people reach out for help, that first of all, it's there. And that in any treatment options and pharmaceutical options that go forward, we have to make sure that we're not increasing the risk to other people.
Actually, that's a great segue to my next question. What is the approximate delay, or how readily accessible is detox in your riding or BC more generally? And what is the wait time for government-funded treatment in your province? Approximate.
Well, unfortunately, and I do have some notes on it, it's actually incomplete data. So here we are talking about a government almost a decade in power. In our province, we have been in a public health emergency for 8 years. And I heard the comments today about should Canada declare a public health emergency, and I want to be clear that it does not help you to declare a public health emergency unless you treat it like an emergency. And so in our province, to have declared a public health emergency and then have no data on wait times for treatment, to have so many communities without access to services, even scaling up things like access to OAT, where, we just saw when the province came and asked Prime Minister Trudeau for, to roll back on his decriminalization parameters of the experiment.
I was proud. They finally decided to copy something Alberta was doing and roll out the virtual opioid dependency program.
And so, but why? Why would it take that long? My question really is that, so here we were 8 years, into an emergency, and only at the 11th hour of a failed experiment, introducing something that could have provided access to a variety of medications and treatments to people across the provinces, particularly in locations where they don't have bricks and mortar services. It's disturbing.
So just today I got a message, and I often get messages from moms that are having a hard time because their children are addicted to drugs. And I got a message from this one mom, and she said, "I'm so sorry it's been so long. I've been in survival mode, fighting to save my daughter. Her 13-year-old friend just died yesterday here in rural British Columbia from overdose at the local hospital after the local hospital released her from an overdose on Friday. Please help us. I can't bear going through another child's funeral. These children deserve so much more than this ignorant system. Doctors should have held her under the Mental Health Act until she could have gone to detox. Another family ruined, many who loved her traumatized, and more deaths to follow if something doesn't change." That message as a mom, as someone that sits there, the fact that 13-year-old beautiful child couldn't get into detox and was released after having an overdose at 13 speaks to how broken this system is. I guess my question to you, Mr. Turco, is, have you seen any increase to detox capacity in the last 2.5 years or 5 years?
I'm sorry, Mr. Turco, very, very briefly.
Not notable, only incrementally marginal. And in fact, when it comes to youth, we know that the only complex mental health and addictions treatment center that was located in Vancouver is actually closing.
Thank you very much, Ms. Turco. Now we'll turn to Ms. Sidhu. You have the floor for 5 minutes, please.
Thank you, Mr. Chair. Mr. Chair, before I proceed to my question to the witnesses, and thank you, witnesses, for your testimony. Mr. Chair, I have one matter I want to address. Hopefully, it won't take much time, Mr. Chair, given the comments of Pierre Poilievre last week, where he suggested he would use the notwithstanding clause if given the chance, and the petition tabled by Arnold Wierson on Tuesday to restrict abortion access in Canada, and the anti-choice March for Life in front of Parliament Hill today. I feel it is relevant to move the following motion that I had given verbal notice on February 15.
Ms. Sidhu, excuse me, there is a point of order.
It is my time.
Ms. Sidhu, there is a point of order.
Mr. Chair, it's my time.
There's a point of order, Ms. Sidhu. Ms. Goodridge, you had a point of order?
I was just curious where she was going with this, but she's made it clear that she's talking about the motion that she had on notice.
Very good, thank you. Please continue, Ms. Sidhu.
I move that the Standing Committee on Health affirms it is support for reproductive and sexual health rights across Canada, recognize that the right to safe and legal reproductive and sexual care in the right to health care, condemns any effort to limit or remove sexual and reproductive rights from Canadians, and emphasize the importance of protecting and expanding access to reproductive and sexual health care, including abortion and contraceptives. I hope this motion is in order, Mr. Chair, and I hope it is not going to take much time to discuss this before I proceed with my question to witnesses.
Very good, colleagues, and to you, the witnesses. So this motion is in order, and now the debate will be on that motion. Ms. Goodridge, I saw your hand. You have the floor.
Thank you, Chair. I'm just wondering, because that was a motion that was sent out quite a while ago, if the clerk could possibly resend to the committee members. And I do know that we have a few new members on the committee that aren't normal members of the committee, so it might be helpful to make sure that everyone actually has that. And could we adjourn debate?
Thank you very much, Ms. Sidhu, and colleagues. We all know that a motion to adjourn debate is not debatable, and therefore we shall have a vote right away.
Mr. Chair, can I ask for when we can vote for that?
I'm sorry, Ms. Sidhu.
I have put this notice.
Ms. Sidhu, we're having a vote on the motion to adjourn debate, and that will be what is there. Thank you. Madam Clerk, if you could call the roll, please.
So a motion to adjourn debate. Mr. Hanley.
No.
Madame Lapointe.
Contre.
Madame Brière.
Contre.
Mr. Pawlowski.
No.
Madame Sidhu.
No.
Mr. Falk.
Yes.
Ms. Goodridge.
Yes.
Mr. Kitchen.
Yes.
Madame Larouche.
Je m'abstiens.
Mr. Julian.
Procedurally, it's inadmissible, so I'm voting no.
It wasn't a point of order. No, it wasn't. Four yeas, 5 nays.
Yeah.
So we have 4 yeas and 5 nays, and therefore we'll continue debate on the motion. And therefore, we shall continue debate on the motion. Ms. Goodridge, I see your hand. You have the floor.
Thank you, Mr. Chair. I think it's incredibly troubling. We've got some amazing witnesses here today that have been presenting some very powerful testimony, and I know I have a series of further questions that I was hoping to get on the record, and unfortunately the government is using this as an opportunity to play partisan politics when it comes to women's health, and frankly I think that it is unfortunate, and so. And I appreciate the fact that the members opposite do want to study women's health, and this is precisely why I brought forward my motion on breast cancer screening. And it was actually interesting this morning. The Canadian Cancer Society actually changed their guidelines, and they deviated from what the federal government and the Health Task Force put forward when it came to women's health. And it talked about their official recommendation is to lower breast cancer screening to 40 years old from 50. And I actually think it shows how behind the times this government is when it came to women's health, and how lacking the task force that has been on health screening here in Canada. The fact that the Canadian Cancer Society had to come out and change their recommendation ahead of what the government has done, because they've been sitting on their hands doing nothing, allowing more women to unnecessarily suffer with breast cancer. And I say this because, as members of this committee know, this is something that is deeply, deeply troubling to me. I lost my mom to breast cancer. I was 21. She was 49. It is something that as my kids get older, as I get older, I think about this every single day. What would this mean if my children had to grow up without a mom like I had to grow up without a mom? My brothers had to grow up without moms. And I talk to people every single day from right across the country that tell me their stories and the impact that breast cancer has had when it comes to their life. And so this is something that I think is very troubling that this government has not acted on. I passed a motion back in April during Cancer Awareness Month, and I think that this is something that we should be prioritized to study in the Health Committee. We've had a tradition in this committee of having these very broad studies and not actually getting to the crux of any one particular issue. And one of the biggest challenges when it comes to having these broad sort of studies, we can't actually find these solutions. And so I wasn't trying to play any
Mr.
politics
Chair,
when I moved
appel
forward.
au règlement.
Point of order. What is being spoken, what relation does it has with the motion?
Committees know that certainly we allow a lot of latitude for people who wish to speak in committee, and I think that has been. I understand that you've not been at our committee previously, but in the spirit of Mr. Casey, who unfortunately is not here, that is the spirit in which we have operated previously, to allow members significant latitude, and certainly those committee members who have been here previously would recognize that. And I realize that I don't sit in this chair all the time, but I will continue to operate in the same spirit that Mr. Casey has for the last 2.5 years. So with that, I will return the floor to you, Ms. Goodridge.
Thank you, Mr. Chair. And I think it is actually extremely relevant to be talking about breast cancer screening, because the breasts are, in fact, a sexual organ, and they have a major role that they play in women's health and women's health rights. And so this motion that was deposited it is exactly on this space. And I think this is part of the overall issue, is we should be having conversations here in this committee about the tragic overdose crisis that is griping our nation, and the fact that in 9 years of this NDP Liberal government, we've had more than 42,000 people.
Yes, Mr. Julian.
Thank you, Mr. Chair. There is an issue of relevance. The motion is reproductive and sexual health rights. This shouldn't even be
thank you very much, Mr. Julian. I think that I've already spoken about that with respect to relevance.
There is an issue
with respect to relevance. Mr. Julian, please, while I'm speaking,
I'm going to challenge you, Mr. Chair, on your ruling.
If Mr. Julian, please,
to speak.
Mr. Julian,
I challenge
if you
your
want to
decision.
continue to be
Président.
okay.
Point of order. Point of order. 1 minute, please, Madame Rouge.
I will have to do no choice but to adjourn the meeting. So, Mr. Julian, I will be very clear. I have already ruled that this is how this committee is operated. You too, sir, have not been here. So shame on you for attempting to do this.
I challenge your ruling.
Meeting adjourned.